Dr. Lara Shirikjian is a board-certified psychiatrist in Los Angeles with a focus in clinical research as a principal investigator for numerous studies of central nervous system indications. Here. She's currently leading the telesupport program of the Armenian Mental Health Initiative, and it's a division of Armenian Public Health to provide professional support to providers in Armenia. Please help me welcome Dr. Lara Shirikjian.
Hey everyone, good morning or good happy Sunday. Thank you for joining us. I know we might be getting people who are going to be in Armenia as well. We are opening this to all, not just to our volunteers and not just to providers, but members of our community, whoever wants to join. This will be recorded and viewed later. So I am going to be speaking to the general public because a lot of the definitions that I'm going to be sharing might be familiar to you as a provider, but for the community, this might be new information. So I'm just going to kind of give an overview of some concepts you might be familiar with. We are going to do this presentation in English, so hopefully we can have as much participation as we're hoping for. I'm going to jump right in, especially since this will be available to view later. And I'm going to share my screen. One moment. Let's just get the PowerPoint going. 1 second. Okay, so I think 1 second should take us to the beginning. Nope, we're on the wrong slide. 1 second, excuse me. Give me just a moment. Okay, so today we're going to be talking about anxiety in the time of the pandemic. And anxiety, is a general term, it's a diagnosis, it's multiple things, but we're going to go through today and look at the concepts of how it's affecting us in this time. I have nothing to disclose financially. This was a presentation I put together for these purposes. Today, we're going to review statistics, criteria to meet anxiety, the impact of COVID-19 in regards to anxiety, identifying the anxiety in healthcare providers, vaccines, and then end with treatment and management. So if you have any questions, please feel free to write it in the chat. At the end, I'll definitely open it up to questions, and we're just going to jump right in. So anxiety is the most common mental health illness in the United States, about 40 million adults, and these statistics were before COVID-19. About 18% of the population had some sort of anxiety disorder last year, and that's usually the rate you get per year. And about 30% experience it in their lifetime. And usually the cases, as you can see here, are mild. It's broken up mild, moderate, severe. And just as expected, most of the cases would be considered mild. Now, anxiety is defined by a criteria that we follow called the Diagnostic Statistic Manual. For those providers who may be watching this in Armenia, from what we gather, you do not have this criteria. So anxiety isn't just one diagnosis, it's multiple diagnoses. And this is how we break it up. So there's separation anxiety disorder, mutism, phobias. Phobias include, for example, fear of spiders, claustrophobia, fear of being in closed spaces, different types of fears like that. Social anxiety disorder or social phobia, which a lot of people identify with when they say, oh, I'm anxious. Panic disorder. And that's not the same specifically as a panic attack. That's not technically an anxiety disorder. It's a specified subsection here. Agoraphobia, generalized anxiety disorder, substance or medication-induced anxiety. For example, if people are using methamphetamines, that can cause anxiety. So it's not true anxiety, but it's rather a result of a substance. Anxiety disorders due to any other medical condition, and then unspecified. So the most common one, surprisingly enough, is phobias. And that's because so many different ones are categorized together. But when we say anxiety, most people think social anxiety disorder or generalized anxiety disorder. And what I'm going to go over today is the most commonly referred one when people say they have anxiety, which is generalized anxiety disorder. And that could be a diagnosis, but it could also be a symptom. So it's not necessarily because you have anxiety means you qualify for a disorder. And that's why I want to go through the criteria. When you go through the criteria, it helps providers give a consistent diagnosis and help with treatment. This creates less chaos. This is what we recommend our providers in Armenia follow, because one person's diagnosis can vary from the others. And this way, everyone's following the same guidelines. So what's generalized anxiety disorder? It's that excessive anxiety and worry, but it occurs all the time, more days than not, for at least 6 months. And it's not just, oh, when I go to a party, it's all the time, going to work, going to school, going to pay at the convenience store. You have difficulty controlling the worry, and you have the following symptoms, at least 3: restless or feeling keyed up or on edge, being easily fatigued, difficulty concentrating, your mind going blank, irritability, picking fights with friends and family for no reason, tension in your neck or certain muscles, and difficulty with some form of sleep, falling asleep, staying asleep, something in regards to that. The anxiety, worry, or physical symptoms cause clinically significant distress in either your social, your occupational, or some sort of relationship, some sort of problems there. Disturbance is not attributable to substance abuse or another medical condition, and it's not better explained by another mental health disorder. So before COVID-19, we had about 110 million disability days per year in the US. So this is being actually paid for by disability, what we pay into through Social Security. I know Armenia doesn't have a system in place like that, but that's how significant it was, because these people could not go to work. And the National Institute of Mental Health broke down anxiety disorders by age. And as you can see, there's not much of a difference. But then when you get to 60 years old, there's a significant drop. So why is that? There's different theories. Think about your mortgage is paid off. You're probably retired or nearing retirement. You don't have teenagers in the home. There's so many things that your anxiety levels will drop. And that in itself shows kind of what the anxiety might be tied into. Now, since the pandemic, we have had a huge influx of visits, telehealth or in-person visits in regards to mental health. But what is the breakdown? How does that work? So those adults reporting symptoms of anxiety and depression were about 11% in 2019. And in 2020, which the pandemic started early, at the end of it, the data gathered was about 41%, half of which were young adults. So the group that was most affected were young adults. And there's variable reasons for that too, right? Work was scarce. A lot of the jobs that the young adults had were more temporary jobs or kind of non-essential jobs as they were trying to build businesses and things like that. So that is one of the factors. Now, if you look at the adults reporting symptoms of anxiety and or depressive disorder, you could see that young adult population is the most, and it just drops down as it goes. The other thing that is important to clarify is in this time is that the increase in those with underlying mental illness, the increase was really people who already had a mental health disorder. So those people who had maybe a history of depression or schizophrenia or bipolar disorder, they were more affected by the COVID pandemic stay-at-home orders. But it was significant. For example, with substance abuse, the rates increased about 20%, certain drugs more than others, alcohol being the most. Cocaine was like 11%, crystal meth was about 20%, prescription pain medications was about 35%. So there was an increase. They did see a drop though once the stay-at-home orders were lifted. So people were at home and abusing what they had at home. The other factor too is a lot of the clinics, for example, a methadone clinic or something that someone's enrolled in was closed. So they couldn't go and get their treatments. And this would cause people to use, misuse, or relapse. So during late June, and late June now is about 3 months after all of the intense COVID stay-at-home orders began, 40% of US adults reported struggling with mental health or substance abuse. And this is the breakdown from the CDC. 31% anxiety and depression, trauma or trauma-related stressor disorders, 26%, substance abuse increased overall by 13, and then suicide by 11. And again, the significance of the suicide is not that people who were otherwise healthy all of a sudden wanted to commit suicide. It was those people who already had an underlying mental health disorder, maybe some sort of cognitive impairment, maybe schizophrenia, maybe a mood disorder, but they didn't just go from being perfectly healthy and mentally to all of a sudden wanting to commit suicide because of the pandemic. So to kind of bring it back to anxiety in our topic today, 61% of people who experience the generalized anxiety disorder diagnosis also experience depression or a major depressive disorder. And again, that's DSM criteria that needs to be met for major depressive disorder. About 42% had a lifetime generalized anxiety disorder, also had substance abuse disorder. So that's really significant. Those really go hand in hand. Now, when COVID-19 was, talked about in the beginning, at first we're saying, oh, we're going to be fine. We're going to be fine. And then fear and varied information started being told to us through the news, through, social media, through friends, family. We were worried about getting adequate PPE and coverage and keeping ourselves safe. We were having stress about what we're going to do in our clinics. Are we going to close our doors? Does everything have to go to telehealth? After 1 year, it's still continuing, right? The PPE anxiety has decreased. The stress of practices has still continued, however, because they're doing partial telemedicine and partial in-person. And that is a challenge for staff because those running those clinics are saying who stays at home, who comes in, how do you differentiate this? So running a practice that many of you might be doing is stressful. Doing therapy from home, or through a computer is a huge challenge. That the therapeutic connection that you may be having with your patient otherwise is that much more strained, and that causes anxiety on the provider and the patient. It may be low and minimal, but it is not an ideal situation. And there's a lot of uncertainty. Certain clinics are, cutting down on hours, cutting down on staff. So the other form of stress that we have been getting is, and again, this is all in the US, was the access to information. We're getting tons of information all day, every day. And how do you know if it's credible or not? If you're listening to a major news channel or reading a major newspaper, you can kind of trust in it. But when you are getting random sources through social media, which there was studies found that majority of people's news was coming from social media posts, how do you regulate? How do you discern which one is true, which one is false? This caused anxiety, whether people realized it or not. So the recommendations were to only follow trustworthy sources. Also, the increased amount of information that was coming was also due to the increased amount of exposure. TV was just left on in the background. People were eating meals and listening to things, listening to people talk about the vaccine rollout. And even if they don't realize it, it kind of ticks their blood pressure up a few notches. It's an extra stress for the rest of the day that they don't necessarily need to expose them to because they're not going to be able to change that. But it does increase blood pressure, anxiety, and affects people without them realizing it. So we've talked about this in the past. Social media is a great tool. It's a great way to connect with family. It's a great way for us, for our sake, when we were in the United States, we were able to find out more information of what was going on in Armenia. We didn't know what was going on. Major news outlets weren't covering it. So when we had social media posts, we saw videos, we saw it firsthand. We thought, oh my gosh, we are given this information. However, it was detrimental to a certain point. We were watching it too much. We were overwhelmed by the news. It was stressful. It was intense, but we couldn't turn away. It's like dopamine. It's like alcohol, and it works on certain receptors in our brain where we cannot turn it off because it's gotten to a certain point where we're just expecting this constant information. And that, bringing it back full circle here, brings up anxiety. So dopamine is that feel-good neurotransmitter, and that instant gratification that we get when we get information is showing that at a certain point, you can't control it. This is all your brain. This is all the chemistry of your brain. So how do we control the exposure? How do we control to minimize that dopamine rush, that neurotransmitter that we can't control? Well, it varies per individual, right? Some people have a little bit more self-control, but you have to make sure that you're aware of what you're doing and how much you're using, just like you would with alcohol. When you know, okay, I know my limit is 2 beverages, 2 alcoholic beverages. Well, you kind of have to do the same as social media, because if you go from, I'm just going to check my emails, and then all of a sudden you are on Instagram for 4 hours, that's a problem, right? And whether you see it now or not, in the long run, that's not helping you get your proper information and balancing out your life. So putting timers, having accountability partners, maybe even removing apps from your phone so that it's not constantly at your fingertips. There's a lot of different tips that you can do. And then the question is, how can we be resilient? How can we be expected to shrug off anxiety? What do we do? So I'm going to get into that now with the treatment modalities, but we tend to, as providers, many of us on this call are providers. What we tend to do is we tend to figure, I'll deal with that later. Let me tend to somebody else. Let me help someone else. I'm fine. So it's really a matter of being mindful, taking the advice we're giving to our own patients and using it on ourselves. So something I wanted to bring up in this, and it's more for an example, is I've been part of the physician support line, which is peer-to-peer, physician-to-physician support. It's a phone number since the start of COVID. And this helped us actually guide our AMHI telesupport line off of this service. And we've been getting calls nonstop since March for physicians, either on the front lines or just in general, physicians that are somewhat affected by COVID, and talking them through what's going on. The most common issue discussed on the phone call for all of my patients, or for all of my callers at least, the primary common thread was anxiety and guilt. And they didn't know what to do. In the beginning, it was okay, but it's slowly gotten worse and worse. And it's funny because the calls have just shifted from different parts of the country. So for the last few weeks, majority of my calls have been from California, whereas in the first 3 months, they were New York and different states on the East Coast. So it's just a matter of at what phase they are at what level of kind of overwhelmed they are. And there were many factors that caused their reason for call, but anxiety and guilt was one of them. Now, something I want to talk about today, which is new, is the vaccine anxiety. So people don't want to get the vaccine. People want to get the vaccine. Should they get it? Where are they going to get it? When are they going to get it? These are all realistic concerns. And they're universal. They're not just for providers. They're not just for people. They're for everybody, even if they're not getting it. So I've heard patients tell me, well, I'm not going to get it, but I'm worried that everyone else is not going to get it enough so that I get my herd immunity so I don't have to get it. So it's that kind of thinking that frustrates a lot of people. But you have to remember, we can't control what other people are doing. We cannot control if other people are going to get the vaccine or not. And that's fine. Eventually, we will get to the point of herd immunity with vaccines, without vaccines, where we'll be able to open up again, where we'll be able to make this work. But in the short term, there's a lot of immediate stresses. When am I going to get my appointment? How am I going to get my appointment? Hopefully some of you have already gotten yours and you can see once the first appointment's made, the second one is super easy. The time will come. It is working. There is something that we talked about in a few meetings is the vaccines in Armenia. So in the US, we have Moderna, Pfizer, and I believe just approved yesterday or this in the last few days was the 1-dose Johnson & Johnson. So this is great for the US, but what about the rest of the world? Armenia has the AstraZeneca vaccine. It hasn't started yet. They're planning the rollout, but from the surveys done in Armenia, it doesn't look like many people are interested in taking it. And what is that? What is the skepticism about that vaccine and why do people not want to get it? Well, there's different theories and we don't know, but you have to think too is when Armenia got hit hard with COVID, almost everybody in Yerevan, or at least congested areas, were exposed to it. So their mentality is, I've had it, I have natural immunity, what do I need this for? We're not getting that many vials anyway, I'm not interested. From what we understand, the rollout is going to be primarily with the healthcare workers. But this is, in fact, the only information we have about what's going on in Armenia. And again, that causes anxiety in a lot of people. So there were several surveys. The census, actually, the US Census did a survey about who's planning on getting the vaccine. So most people said they'll get it. Some said probably not, some were absolute not. Now, the breakdown is interesting of the age. So the younger crowds were a little bit more skeptical. And again, why is that? Is it because they're less likely to fall deathly ill? Is it because they've been the demographic exposed more? So they already have that natural immunity. They're thinking, what's the point? So it breaks down. But when you get to 65 and above, they're pretty confident. Definitely 71% are getting the vaccine. So this is just to kind of give you an idea of what's going on. Now, in regards to the vaccine too, and I'm not really going to go into here, but there is a lot of differentiation in ethnicities. And certain ethnicities are very much adamant that they are not going to be getting the vaccine, or that they're maybe getting less educated in those communities. And that's comparable to maybe what's going on in Armenia, certain educational platforms. There is information, and we have not really put it in the slide deck here. I haven't put it in the slide deck, but that sorry, I get so distracted by every time there's a ding. What was I saying? I forget. Okay. I don't think it's important. Oh, I remember. Okay. So the difference of the ethnicities and the education, the rate of a higher level of education is more closely tied to the rate of actually someone getting the vaccine. So inversely related with your years of education with getting the vaccine. So kind of bringing it back to anxiety again, what can we control? What can we not control? So we can control following the CDC guidelines, washing our hands, keeping ourselves healthy, having a daily routine, managing our own actions, managing our own expectations. What can't we control? We can't control the pandemic. We can't control the vaccine rollout and who's getting it when, and we can't control who's getting the vaccine and if they're going to take it or not. But we can be mindful of these two things. And if we know that we have no control over it, we have to get to the point where we can just let it go, right? Now, there's different treatment modalities. We've got therapy, mindfulness, exercise, medication. And these are the go-tos in our clinics. So there's different types of management trainings here. We've got relaxation training, and this is being taught with, again, a provider, a therapist, about how to control the major muscle groups of your body to help you with relaxing. Certain forms of breathing, diaphragmatic breathing, and ways to avoid hyperventilation. You see in the movie someone blowing into a paper bag. Don't try that, because that could backfire. So this was something you have to kind of retrain yourself to breathe properly. Positive thinking and self-talk. So replacing those negative thoughts with positive ones. I can do this again. I've done this before. I've been here. I'm not going to die. This seems terrible. It's going to be fine. People tend to catastrophize and go to the worst case scenario. So to kind of bring it back, saying, okay, what is the worst case scenario? Okay, how realistic is that? Let's take it down a couple of notches. So there is a form of therapy called assertiveness training. This is teaching how to express wishes, opinions, and emotions appropriately and without alienating others, because that can happen a lot. If you are anxious all the time, you're going to have a hard time keeping those relationships. Thought stopping, distraction techniques to help you with, pushing out those negative thoughts. Small things can make big impact. And again, if you've got a very significant anxiety disorder, this is going to be hard to do. But if anxiety is just creeping into your daily life, these are ways that you can control it on your own at home. So making lists, organizing your plan, prioritizing what's important for that day. When you feel overwhelmed, saying, okay, what if I could only get one thing done today? What is that one thing? Talking it out with friends or peers or loved ones, focusing on what you can control, letting go of what you can't control, sticking to a routine. And it's okay to regress. It's okay to say, you know what, I'm going to take the day off. I'm going to not go to that one thing that I thought I was going to go to. I'm going to stay home and I'm going to do something for myself. And that's okay. It just can't be all the time where it affects your normal lifestyle. Lifestyle modification is important, because this could be with your diet, your sleep, what are you eating, are you exercising? These are all key components to health, because mental health is completely tied into your physical health. Limit setting. So if you are a provider, make sure that you separate yourself from their problems. It may seem overwhelming, especially if we are helping people who are in Armenia. We're really taking on their burden, their thoughts, and that is stressing, and distressing. So remember to separate yourself from other people's problems. And it's okay to have some anxiety, use it to your advantage. So anxiety can be helpful in certain ways. Biologically, we have it. There's not one person who doesn't experience anxiety. It's just a matter of how much you want to prioritize it. So are you going to, are you going to, sorry, I get distracted, there's things popping up. So are you going to fight or flight? Are you going to flee from the situation? Are you going to address it head on? These were things that were done biologically so we could get through it. So for this time during COVID, what is that a little extra anxiety about? Maybe COVID in the office. Okay, I'm going to spend a little bit more energy cleaning. That therapeutic practice might help us. Let me see here. Okay, so medication. So this is more my field of expertise. I am a psychiatrist, so what I do day in, day out is prescribe medication. The medications that we most prescribe are these. These are the main ones that we use for anxiety. And their Gabapentin right there is just off-label use. And off-label use means it's not FDA approved for this indication, but it is FDA approved. So we use it all the time. Benzodiazepines are the Ativan, the Xanax, the Valium. These are the things that, most people ask for because they work. It's not that they're bad. We just don't prescribe them often because they are a controlled substance. They can become addictive. You can lose, the tolerance level will go up. They are a little bit more difficult to manage in the long run, but in the short term, they're great. They're great solutions, but they are more of a Band-Aid. You're feeling anxious, you take a medication, half an hour in, you're feeling a lot better, and it wears off very easily. So this is the most commonly asked medication in our clinics, but probably if you're going to the appropriate clinic is not going to be prescribing it for very long. For those providers who are listening, you do specifically, I'm in California. So in California, every time I have to prescribe a Xanax or an Ativan, it is my responsibility as the prescriber to look up to see if they've gotten it from somewhere else and to register that I'm giving them this medication. And they call this the Cures program. And this is through the government's website. So be mindful if you're prescribing this medication or if you're having this medication prescribed to you, you are being entered into a database because it is a Schedule III drug. Buspar or buspirone is a medication that's specifically for anxiety. It's not controlled, it's not addictive, and you could take it every day. It's not an as need be as an Ativan or a benzodiazepine, but it's relatively safe to take, and it is it works. It doesn't work that great according to my patients, but it works. So if you've got an anxiety level that is probably of mild, this would be the medication for you. SSRIs, or selective serotonin reuptake inhibitors, are antidepressants, and you take them once a day, just like you would an antidepressant, or for depression. Like I said, anxiety and depression go hand in hand. So this medication is probably the best one that you could take if you have anxiety that is continual. So if you have generalized anxiety disorder, or if you have anxiety that is not a short-term problem, this is the medication that you should be taking. It takes a little bit longer to kick in than it does for depression symptoms. So you have to give it, I would say, about 3 months. But anxiety and depression work in the same way. So these medications like Prozac, Effexor, Lexapro, these are great choices if you have anxiety. There is a medication called Bupropion. It sounds like a lot like buspirone, but it's a different antidepressant, and that's Wellbutrin. It works a little bit differently, and it doesn't cover anxiety. Gabapentin, like I said before, is off-label use. This is a medication that we give for seizures or maybe sort of for like diabetic pain, leg pain, things like that. It works for anxiety. It works really well. Usually the patients take it 3 times a day, and that's maybe the reason why we don't prescribe it as often, because you do have to take it more often. It wears off quicker. And this medication we like to give for patients with drug abuse history because they can take it as need be. It doesn't have to be an everyday medication, but they can take it as need be like they would Ativan or Xanax, and it's non-addictive. Hydroxyzine, the trade name is Vistaril, is an antihistamine, and that has actually found subsequently when people are taking it as an antihistamine to cover anxiety. People also take this at bedtime because it kind of makes them sleepy. This is also non-addictive, so this is a good choice. And this can also be taken on an as-need-be basis. So it's important that you have these medications prescribed to you and you're not just getting them from your grandmother's, medicine cabinet. You have to discuss this. The best treatment is the combination of therapy and medication for anxiety. You have to have this prescribed by a prescriber that can prescribe medications. And you have to note that certain medications, and your prescriber will tell you this, have certain black box warnings. Like SSRIs have a black box warning of increased suicide in young adults, and this automatically comes. And again, that cures registry that I brought up. So there are resources in the US. The National Alliance of Mental Illness is a great resource. Even if it's not you, if you have a family member with anxiety, this is a good choice to look into. Just check out their website and they have a lot of great information. If you are a physician, you're welcome to call our physician support line if you're having any questions or anxiety yourself. It's an anonymous hotline that we've had since March of 2020. And then if you don't know where to send a patient, you're welcome to call 311. And this is locally here in the US, in Armenia. That's my next slide. But here you can call 311 and you could say, I have anxiety, I need to find a provider, or I need to find therapy. I live in this zip code, where can I go? And that's just kind of like a 411. It's an information line of where to get help. So resources in Armenia are a little different than here. We're still helping AMHI, our group here, and many of you are our volunteers. We have the telesupport line, and this is still open, and please check our website. The hy.amhi.org is in Armenian if you're interested in seeing it in Armenian. And we are currently helping a group in Armenia develop a hotline. So kind of like an internal 911. So if someone's suicidal or if someone needs to seek out help, to get referred to a clinic locally or to talk to a counselor or someone who's going to triage their problems over the phone and tell them what they need help with. And if you're interested in helping us, if you are a volunteer, if you are interested in your clinician or a provider, please, join our volunteer group. And again, you can find that on amhi.org and help us develop that, because we've got, I think Emily's on our call today. She's leading that with Nora. So hopefully we can get more help for that. And I'm going to open it up for questions. Any questions? I raced through it. I talk really quick. I was distracted by all the beeps. I'm sorry.
Dr. Lara, Shirikjian, thank you so much. You guys, if you have questions, go ahead and either write it in the chat or, we're a small group if you prefer to just unmute and ask.
Yeah, just unmute and just chime in. Let me stop the, there we go. Let me see in the chat. Oh, you wrote it. Can Wellbutrin cause anxiety? Good question. So it might. Wellbutrin, again, works really well for depression. It kind of works in the same way. So again, this isn't really, I'm not really putting it into the proper medical terms, but my patients who have a history of meth abuse love Wellbutrin. It works on the same areas of their brain. So it doesn't cause anxiety, but it doesn't help alleviate anxiety. People who tend to want Wellbutrin like this type of pace, it doesn't really subdue them. And the other reason that people like to take Wellbutrin is that it is relatively weight neutral. It doesn't cause a weight gain, where some of the other antidepressants do. Anita, you're on mute.
I saw that it notified me. I was intrigued by the paper bag, so I must have been misinformed with that. So tell me about the backfiring of the paper bag.
No,
having a panic.
It works, but some people do it improperly, and that's all it is, right? They could hyperventilate more, and then they would notice, like, I can't feel my fingertips. I can't feel the edge of my mouth, because they're not breathing properly. They're breathing too fast, and they're not really breathing properly into that paper bag. So I think that breathing treatment or breathing, maybe even watching a YouTube video, but how to breathe to calm yourself down is not intuitive. You could end up hyperventilating.
Do you feel comfortable with demonstrating that or telling us like, or no?
I mean, I don't even have a paper bag nearby,
Okay.
but I would say check out a YouTube video and yeah.
Okay.
Hi, I have a question.
Mhm.
I've got a lot of patients asking me about psilocybin. They hear it in the news, and I know some folks are kind of, in that gray space that sometimes things happen. They're doing microdosing of psilocybin, and honestly, I've been kind of impressed with some of the results that they're coming back and telling me about as I kind of, monitor their other health issues. Do you have any experience with that, or what are your? I know it's Schedule 1, and it's not legal, and there's all those issues. But from an effectiveness perspective,
Well, again, because it's not FDA approved yet, I do clinical research, and we do have a study right now that is going with it. But as a provider, I have made extra efforts to clarify kind of what I recommend. And I have to recommend what's FDA approved or something that I've done that's tried and true. Like, for example, gabapentin's off use, but I use it all the time. It's relatively safe. For medications like that, if I don't have the correct data, it is irresponsible of me to recommend it. I can see the benefits, but I have to follow kind of the guidelines. This is the same advice I'd give to someone who's using things that are awfully herbal supplements,
right.
things like that, because I cannot read the articles. There is no scientific research. I can't be confident to do that unless I firsthand tried it on my own patients.
I
And
would love
I'm
to.
more conservative. I don't do that.
No, I totally am the same way. I'm not actually recommending it. I'm sort of like documenting it more like in their charts and trying to, kind of keep track of it, because I do think that clinical research is needed in the area for sure. And then and then just maybe I can do this offline with you, but real quick, I'd like to get some more information about how to get about that clinical trial and for some of my
yeah. And you know what, if you're ever interested in participating in a clinical trial or having information about what's already being done, go to clinicaltrials.gov. And they have to be transparent. So if there are psilocybin studies, if there are ketamine studies going on, it'll tell you exactly where they're being done, if they're enrolling, if they've been shut down by the FDA, if they're in the pipeline. All of this has to be transparent. And that's the beauty of the US, because they do keep all of this transparent. So it's clinicaltrials.gov. And it's pretty easy. There's a search bar. You can just type in keywords and it'll pull up all the studies that are currently enrolled in the United States.
Yeah. And of course, with people that are just kind of doing it on their own. I mean, obviously the work with me is confidential. We're providers. So just as far as that legality of what are your thoughts on that? I mean, obviously I'm not going to go and, report my patients to anybody. Right.
Right. And I mean, I wouldn't concern myself with doing that either. You have to remember, are they abusing other drugs with it? There's a lot of factors, right? So if you have a person who's abusing drugs and then they're enrolling in clinical trials or they're enrolling things like this, there tends to be checks and balances. Like, for example, in clinical trials, they do a pretty thorough check to see if there's a drug abuse history or if there's concern or if there's suicide history, or if there's some concern that this person's going to do further harm to themselves. Now, some people are just going to clinics, paying cash out of pocket. No one will be the wiser. And that's their discretion, just like they would be going and drinking 10 alcoholic beverages a night. We cannot control that. We can only guide them and say, I don't recommend that for you based on your history, or I don't recommend that to you because of, your significant anxiety. This could be worse, right? Ketamine studies, for example, in a similar thread, they cause dissociation. So what do you do for a patient who's really highly anxious that all of a sudden dissociates? Is that going to make it worse? Maybe it might alleviate some symptoms, but in the short term, is it going to make things worse? Is it going to make them relapse? These are all things you have to think of. But again, as far as reporting, we do what we're supposed to do. If you're using a controlled substance, you report it the way you're supposed to report it. If you do more than that, you're just going to drive yourself crazy.
Yeah. Thank you.
You sure?
Lara, we have several questions. I'm just going to
go. Yeah.
Do you recommend trazodone for anxiety-induced insomnia?
Yeah, trazodone works great. Trazodone is technically an antidepressant, or we prescribe it as an antidepressant, but most people just take it for sleep. Trazodone's a great medication. It's relatively low side effects. Usually people take 50 or 100 milligrams. You don't have to take it every night. You could take it as need be. It definitely works. I prescribe this to maybe 20 to 40% of my patients who need help with sleep. Insomnia it doesn't matter what insomnia is, you want to just treat the insomnia, right? So there isn't a specific medication that works better for anxiety-induced insomnia, unless, dare I say, Ativan, because what it does is really just relaxes you and then you're able to fall asleep. But again, you don't want to be taking Ativan every night to go to sleep. So other medications that we recommend is Ambien, which is a non-addictive medication, or it's called Zolpidem is the trade name. You could take this in 5 or 10 milligrams. The extended release is like 12.5. It's relatively, low side effects, but there are different side effects that some people just cannot tolerate, which are nightmares, sleep behaviors like sleepwalking or sleep eating, getting up and doing things while you're in this kind of in between sleep worlds. Not that often, but it is a problem. So you have to make sure you warn your patients of that. So maybe on the first week of taking it, make sure the family has, or someone who's living with them keeps an eye and make sure they're not going to, make a full meal at 2 a.m. Because they might not remember the next day. Again, rare, but it is a possibility. So Ambien's a good one. Trazodone is a good one. People take Benadryl. So just regular Benadryl, it can be prescribed, like Banafin is a prescription. People take 50 milligrams, start out at 25 milligrams. That medication helps, but there is some grogginess the next day.
Also, what if someone takes Ativan twice a week? Is that addictive if they're just taking it?
So it's different for everybody. And again, to say who's addicted and who's not is a stress. Is a stretch. We cannot predict that. Twice a week seems reasonable. Ativan works if someone's going through a really stressful time, or if they're going to be, they have a fear of flying and they're just going to take it when they're on the plane, or they're going through something and they need it temporarily. The problem is the long-term use. Are you taking it 2 times a week your whole life? What is the reason that you're taking it? And it's not that it's bad and you're going to become addicted. It's just, let's get to the root of the problem, because again, it's a Band-Aid.
And I know Yadaz just shared CBT is highly effective for sleep disorders
in concert with medication. I think CBT is great for anything in combination with medication, anxiety, depression, everything. CBT is safe. There's no side effects to CBT, right? It's hard though, because you have to find a therapist that you like. You have to become connected with them and you have to trust the process.
Yep.
And that's the hardest part. If you can get past that, or if you can find yourself the right provider to trust, CBT is great. It's found to be so effective. And again, medication helps with that too. So in the regards to Ativan, so if you're saying, okay, I have a fear of flying, well, you're going to do some CBT and Ativan to get through it, to kind of calm yourself down, to do the next steps, to push yourself to the next level. That's going to be a really successful combination.
Great. Monica's asking, is there a medication you would recommend someone who has a lifestyle of heavy drinking? This is an important one.
For anxiety specifically, I'm guessing that question is, or is this to Monica, if you could clarify the question. So if it's for anxiety, who has anxiety, if it's an anxiety medication we're talking about for someone who drinks a lot, I would say for anxiety, yeah. So I would say bupropion is good, hydroxyzine is good, but hydroxyzine can alter blood pressure. So if they've got high blood pressure, be mindful of that. Again, they're not going to be doing this on their own. They're going to be doing this with the supervision of a clinician who's providing this medication prescription. So I would say bupropion, gabapentin, hydroxyzine. Those would be my recommendations.
Great. What would you recommend as best sleep aid for those whose main symptom is sleep disorder? I think you may have answered this. How many milligrams melatonin, if you recommend that?
So I get milligram questions for melatonin all the time. No one asks about milligrams more than melatonin. And I think it's funny because one day I went and looked at melatonin bottles, and I've never actually taken it myself, so I can't speak on that. And I also can't speak on melatonin in general because, again, it's not FDA approved. So the proper research and medical articles that I read on medications and all the information that I've been gathered has not been given to me for melatonin. So I cannot confidently recommend it because of those reasons. But it's always a question of milligrams because these bottles are very inconsistent. So it's like Tylenol is 325, we know it, right? Or we know the specific milligrams. But melatonin, because it's probably mixed in with other things, there is no real true milligram because it's combined. But I think 5 milligrams is what people were taking. So if you're asking me about melatonin, I'm not going to be able to give you exact dispense amount. I do know many of my patients take it, though. It's relatively safe, but I don't have the data on what milligrams you actually need to properly work.
Dr. Galcian saying you should be using the lowest effective dose. There's
Yeah.
another question that's coming in elsewhere. When you take Pristique, is that supposed to stop anxiety? Do you know?
So Pristique is like, it's a medication that's more for somatic pain. For example, fibromyalgia, or if you have depression that, causes a lot of that muscle tension, or you have chronic pain issues, chronic migraines, things like that that are tied into your emotional state. That's a good medication. It could help with anxiety, but it's not indicated to be for anxiety. So if you've got other issues, that's probably why it's been prescribed to you, because you've gone to the doctor's office voicing concern over some sort of somatic or physical pain or symptom that you're having along with your emotional issue.
Interesting. Good. What else, you guys? Someone wanted you to list in the chat the medications. Monica, do you want to clarify which medications that she listed that you wanted her to include in the chat? Maybe Dr. Galcian can write it out if Dr. Shirikjian.
She's our medical monitor over there.
The three
I think she's post-call, so we appreciate that she's on here. Thanks for the support.
The 3 medications that you...
Oh, so hydroxyzine, buspirone, and what was the other one I said? Hydroxyzine, buspirone, and gabapentin.
She want maybe oh, there we go.
Yeah, she's typing. Thanks.
Is on.
How about, I mean, if there's no other questions, maybe I can put it out to you guys, because most of our viewers right now or you guys are providers. So as therapists, as clinicians, as providers, what challenges do you have with anxiety or managing your patients with anxiety?
I mean, my issues are with my clients are drinking or using. That's like the hardest part. And then there's a lot of on and off. As a therapist, clients go on and off, not wanting, they get worried about being on meds for more than a month every day. So they try to get themselves off. So that's the biggest challenge as a therapist with my clients.
Right. And that's why I kind of wanted to put in that PRN or as need be dosing, because that's what people like about the Ativan, and they keep it in their purse, just knowing that it's there. But to take a medication every day, for some people, that's just daunting because they don't see the light at the end of the tunnel. Like, am I going to be in an antidepressant the rest of my life? I'm not depressed, I'm anxious. Yeah. But it's the stigma of that taking that daily medication rather than I only need it when I need it. And people like that. And it makes sense. It's just one less thing you have to worry about. And again, people like the benzodiazepines because they actually work and they work quickly. These medications will work and they'll be more subtle. So if you're talking to your patient about it and just say, you know what, this may not feel the same way when you took a Xanax, but this will still work in a different way where you don't notice it coming on and coming off so strong. And again, it's behavioral too. It's not just the medication. So that combination with CBT, just saying, okay, next time you're feeling this way, be mindful of it. Stop and say, okay, wait, why am I feeling this way? What's really the issue? Instead of just popping a pill. And this is our culture this day. This is humans in 2021. We just want to fix the problem. We don't want to think about it. And that's, part of the problem. So if we can say, okay, why am I all worked up right now? Let me take a minute. And if it becomes to a point where it's unbearable, a medication can help.
Yadaz is raising her hand.
Can I chime? Yeah, I just want to chime in on the subject of kind of the quick fix. Lara, my biggest challenge as a non-pharmacologic clinician, right, as a psychologist, is that a lot of people with anxiety have sometimes people come in with a long history of reassurance seeking to make their anxiety go away. And that's become like a behavioral pattern. So whether it's through medication or whether it's through behavioral reassurance, they're used to having the anxiety go away very quickly. And so my challenge as a therapist is teaching them how to tolerate their anxiety and tolerate the uncertainty, slowly with time to become a little bit more comfortable with it, you know, from my point of view, again, not being a medication provider, but as far as our therapeutic work is concerned, that's my biggest challenge, is sort of constantly getting people used to just the idea that you're going to sit with your anxiety for a while, and then it will get smaller the more you sit with it. And there sometimes isn't a quick fix. So I'm just wondering from your point of view, how you would deal with that.
Well, it's different because as far as me, because I'm a psychiatrist and because of most of what I'm doing is medication, they're coming to me because that's exactly what they want. They know exactly what they want. I'm not offering them the therapies that they actually need. I think this question I'm going to throw back to our group as providers who are doing therapy. How do you navigate that? How do you really slow it down? Like she said, it needs to be slowed down and said, okay, you need to live with this anxiety for a little bit. You know, because I don't do this day in, day out, I want to ask the group, anyone want to kind of chime in and say? Anybody?
I mean, I can just add that, you know, it is a challenge, and it just takes slow and slow and steady. You know, it's like they think they're not asking for reassurance, but then as soon as you're done with a therapy session, it'll be like, how did I do? Or, you know, like there's this constant underlying reassurance seeking, which is a part of the anxiety itself. Anyway, you asked for challenges, so I wanted to bring it up.
It is a challenge. So we have to kind of, I think, take it back, and this is like a bigger conversation, but take it back to the way we are raising children now. Whereas, you know, in the 50s and before, there was no, you're doing a great job, yay, yay, yay. And then the parenting shifted to you're doing a great job. You're amazing. You're the best. You're the best artist. You're the best Lego builder. You're the best this, right? So they're constantly seeking reassurance, assurance, validation.
Right.
Because they were getting that for so long, where before that wasn't really the culture of parenting. So now there's a whole, I don't know if any of you are familiar with the nonviolent parenting. It's a terrible term, but it's called nonviolent parenting. And it basically is telling you to not praise your child every time they do something. So it's more changing our words. So a kid draws a picture and shows it to you, and you say, wow, you drew a picture, right? Just stating it, not saying, oh my God, what a beautiful picture. That's amazing. Just saying, what do you think about your picture? Kind of asking them questions to see how they feel about it, and not us projecting and making them feel better and validating them for something they don't need praise or validation for. So if they get 100% on a test, they come and you don't say, oh my God, you're amazing. Congratulations, you did so well. It's saying, how do you feel about that? Wow, you brought home a paper. Tell me more, you know, just kind of, I don't know. That's just something I just thought of when you brought that up. It's a concept.
Margarita has a question. She has her hand up.
Yes, hi. I just wanted to get back to gabapentin because it has a wide range of dosing, like for neuropathy and anxiety. So what would be your best recommendation to start and increase, and how gradually or suddenly we can do it?
So I prescribe usually 300 milligrams. And then some patients will only need it once a day, sometimes 3 times a day. And I have patients, like I have a bipolar patient right now, and she takes a lot. She takes 600 3 times a day. And that's a lot, but for her, she has gradually increased it up to that day, and that's how she kind of gets through. And then she has a lot of different components, inpatient, outpatient, but I would say 300 milligrams up to 3 times a day is a good range to be at, but to start out once a day.
And if it's an elderly, like I mostly work with geriatrics, same?
So because I'm not normally changing it for that, I can't confidently speak on that, but I would say be as concerted as you can be. So start with the lowest dose, try 1 time and see, you know, cut a pill in half if they're taking it for something else. A lot of the times it might be dual effective. So for example, if they have neuropathic pain or they're diabetic or something like that, and they're not on this medication, they're on something else, maybe switch it to this so it kind of has a dual effect. Look at their medications, check the drug-drug interactions, but do the lowest possible dose and see how it goes.
Sure, thank you.
Sure.
And I know Hagina made a comment about highly anxious patients not responsive to 3 to 4 SSRI, SNRI. How do you feel about California rocket fuel?
What's California rocket fuel?
I don't know.
I'm not even familiar. Hagina, what's California rocket fuel?
Chime in, Hagina.
You don't have to show your face. We can hear your voice.
And then she said this may be
So,
yeah.
it's actually a combination of Effexor and Mertazapine.
Oh, okay. Yeah.
I've only seen like psychiatrists prescribe that, and patients come to me with it. But I personally haven't been comfortable doing that combination? I just wanted to see your take on it.
Yeah, that's fine. So Mertazapine is an antidepressant, but we give it more for sleep as well. So it can be in like 15, 30, and 45 milligrams. And ironically enough, the higher the milligram, the less effective it is for sleep. And so some people thought like, oh, you're not sleeping that well, let me increase your Mertazapine, but it doesn't really work that way. So that's fine. Usually I would add like a 15 milligram and it just helps with sleep. But the combination of a therapeutic dose of Effexor plus Mertazapine is not going to be an issue. That works.
And Belinda made a comment about mindfulness is the best way to teach them to learn to tolerate. And Nora, I'm seeing more and more anxiety and depression in teens, due to COVID, and some have suicidal ideation that they've never had before after assessing and realizing they're safe and consulting with parents.
Yeah, I might have gone really quickly through the slide. So that slide when I was talking about COVID and the increases, so the largest hit was about almost half was the young adult population. And the suicide rate that went up about 11% on that CDC slide basically was, and I was saying these are people who already had an underlying mental condition, but that we did see an increase in this population. And again, they might have already been predisposed to being depressed or anxious. Maybe they have a family history, there's other issues, but this kind of tipped it over. This was the threshold that they met to kind of meet the criteria for one of these disorders. So this did go off this did, become an issue more so. Suicide rate did go up, but these are all people who already had an underlying issue. It didn't just come out of nowhere. But for this young adult population, it was hard because you have to remember they've lost their social structure. And for a teenager, their lives pretty much revolve around a social structure. And biologically, that's fine. That's how it's supposed to be. Peer influence is so significant, more important, actually, they have studied, than adult influence. So if your teens are surrounded by the proper groups, they're a lot more likely to not do certain behaviors that we want them to, rather than as the parents to tell them. So the peer influence is huge. And now if you're not going out and seeing these peers and you're only talking to them through social media and maybe seeing, oh, look at them, they're having fun and they're in a pandemic and I'm at home stuck and I'm not having fun, and this person's the same age and goes to my same school, how am I going to navigate this? And if they're not communicating this properly with someone, it becomes a big issue. So if you are a parent of a teen who is struggling, my recommendation is to ramp up that communication. Ask them open-ended questions. Just sit quietly with them and find out more. Don't ask them directly like, why are you sad? What's going on? Just kind of give them more opportunities. And it's not going to happen on one session. Just spend a little bit more time just talking to them, asking them open-ended questions, starting out by saying, you haven't hung out with your friend so-and-so in so long. What are they up to? And then they might just go off and start saying what they say. And you can kind of listen and just say, not everything is as it seems. Maybe reach out to them and maybe we can set up something safely. You guys can hang out outdoors or find some sort of solutions.
I know some people are signing off. I just wanted to make a quick announcement, and we'll put it in the chat, that we have been, Hagen has been working on this. We're putting together a providers list in the diaspora. So if you're a therapist who would like to join that directory, Hagen and I will put the website, or she already listed the website in the chat, just to make sure you put your information, you include yourself, so that if people if they need someone in your area, they can call you.
Well, this is good. I speak really quickly and I got distracted a few times, but we made it
But look,
right on time.
1 hour. I love it.
We did it.
People's questions.
I'm sorry, I have a quick question in regards. I was trying to register myself on that website, but it only gives an option for therapists, and I'm a nurse practitioner.
Yeah. For the AMHI, through AMHI?
Yes.
Okay, then just email us at AMHITELE, so AMHITELE @gmail.com. We're doing some changes on the website, because before we had you sign up for your own hourly shift, but because the demand hasn't been as high, we're going to just kind of do direct surveys and we'd match people up. So just email, just say I'm interested. Did you fill out the survey on amhi.org about being a volunteer?
I think I started and then I didn't find an option for myself. Like, who do I?
Well, definitely. And I'm glad you brought that up. Maybe we don't have that. We need to put that in the drop down. That's important.
And
So
if
we will.
I'm
Oh
able-
yeah, Helena, because Helena works with Lev to do this. She said you can join now. The new form is different. So yeah, we were changing it. So please try again.
And in terms of like prescribing, or are we just advising it, or like
Just advising. We're not prescribing. We're not providing direct patient care. We're going to do whatever we can to support our peers over there, our colleagues over there. And if you're interested in developing the hotline, Emily and Nora are overseeing the hotline. And this is different. This is like internal in Armenia. And the telesupport is more just for any provider, you know, social workers, midwives, anybody who's calling in who needs help somehow.
Okay, thank you.
Yeah.
So I just wanted to clarify one thing. We do have two forms. The first form is to join AMHI as a volunteer, and you can be a student, you could be a nurse practitioner, you could be a licensed psychiatrist, psychologist, it doesn't matter. We are just taking volunteers. The second form for the database is for only licensed providers who care for any type of mental health. So if you're an LMFT or even a family medicine physician who does a lot of mental health care, then you can join that database. We just ask that you are licensed and that you can practice independently.
And Rosanna is asking, what is the youngest age you have prescribed SSRIs for?
So I'm an adult psychiatrist, but during residency, obviously we had child psychiatry rotations. And I worked for the county system, so it's a little bit more aggressive than other places than a private practice. But the youngest that we prescribed for at that time, we had a 8-year-old that we were prescribing it to. So it's case to case dependent. Obviously, there's a lot of issues at play, but follow the guidelines, because they will have pediatric dosing on the guidelines for all of the medications. And if you guys are prescribers, I don't know if you have it, but I love it. I use it all the time. There's an app called Epocrates. They have a website too, but I use that all the time. I really like it, because if I'm in a pickle and all of a sudden I'm trying to remember what the half-life is of something, it'll be there. Or the milligrams for prescription, in case you forget, or you don't want to go and look it up with the inserts. That one's great. Yeah, Helena uses it too. Okay, good. All right.
And I know we had a couple people just join right now. I hope they didn't have the wrong time, but it was nice to.
Well, we're gonna have it. We can have it, this talk saved somewhere, and we'll announce where we're saving it, so you can listen in. Hopefully, it was informative.
It's on our Facebook page. You'll see the recording there. So I'm going to put this in the chat in case you guys don't follow our Facebook page. So you'll have the recording there, because we were streaming live on that page. So you'll have the recording there in case you missed the earlier part. And do we have any last questions before we wrap up? Lara, you've been absolutely amazing, very informative. You've been getting a lot of wonderful feedback with how informative and how helpful this talk has been. Much needed talk for sure. And we hope you do another grand rounds in the near future with us.
What I will say though is I'm not doing anymore. I want you guys, I want our community to chime in. Dr. Babikian did a great one. I didn't do grand rounds justice today because hers was amazing. But this was just something that I know that people wanted to talk about. So I just, said sure. But I would rather it be coming from our group, because there's so many awesome providers in our group, and I'd love to hear from them and their expertise. So please, if you want to do this, again, you don't have to sit here. I didn't have citations and things like that. It's casual, just for us. It's presentation to our peers. So if you have something that you're passionate about, or you do day in, day out that maybe other people don't do, please sign up. Sevon sent out an email to our volunteers, and she probably will send another one out with our next grand full meeting. So sign up if you're interested. I know we've had a couple other people, and we're hopefully going to reach out to them too, for them to do the next one.
Thank you so much. Thank you everyone for joining us. Have a beautiful Sunday. Thank you.